Welcome to ICU Primary Podcast.
Hi, I'm Maddie.
Hi, I'm Swapnil, and today we are going to discuss about neuromuscular agents. Now, before we move into the actual podcast, well, Maddie, welcome back from your holidays.
Thank you.
How was your holidays?
It was really good. Highly recommend it. Went to America, visited my sister, and if ever anyone gets the chance, go to Yosemite National Park. It's amazing.
Oh, great! And did you meet Donald Trump?
I didn't, but I counted myself lucky for that.
Okay, let's get into the podcast now. So, Maddie, can you please briefly describe the physiology of the neuromuscular junction and the difference between depolarizing and non-depolarizing muscle relaxants?
Sure. So when the extension of a neuron, otherwise known as an axon, reaches the muscle, it branches into a number of axon terminals. At the end of each terminal is a swelling called the synaptic end bulb, which contains vesicles full of acetylcholine. Each synaptic end bulb forms a junction with a sarcolemma of a different muscle cell, known as the motor end plate. This junction is called the neuromuscular junction. The gap between the nerve endings and the muscle cells is called the synaptic cleft. Transmission occurs when an action potential at the neuron causes depolarization of the cell membrane, which results in an influx of calcium. This causes acetylcholine release from the vesicle, which diffuses across the synaptic cleft to the motor end plate and activates postsynaptic nicotinic receptors, which results in sodium influx. The sodium influx produces an electrical potential called the end plate potential, which, if large enough, results in depolarization and propagation of the action potential across the muscle. The muscle contraction then occurs via excitation-contraction coupling. The acetylcholine released also binds to presynaptic nicotinic receptors, which further enhances acetylcholine release. Acetylcholine is removed by diffusion and by destruction via acetylcholinesterase. Neuromuscular blocking agents are all structurally related to acetylcholine and can be classified as depolarizing or non-depolarizing agents, depending on their action at the post-junctional nicotinic receptor. Depolarizing agents are agonists at the acetylcholine receptor, resulting in ongoing depolarization of the motor end plate, making them unresponsive to subsequent impulses. As excitation-contraction coupling requires end plate repolarization and then repetitive firing to maintain muscle tension, depolarizing agents results in a flaccid paralysis. The only depolarizing agent currently available is Suxamethonium. Non-depolarizing agents such as Rocuronium competitively block the acetylcholine at pre- and postsynaptic nicotinic receptors and thereby prevent depolarization.
Okay. Can you please outline the difference between phase 1 and phase 2 block?
Depolarizing muscle relaxants usually result in a phase 1 or a depolarizing block. However, after prolonged exposure, they can result in a phase 2 or a desensitizing block. Phase 1 block results in muscle fasciculations preceding paralysis and an absence of train of 4 fade. Train of 4 stimulation is when 4 electrical currents are delivered at intervals of 0.5 seconds to a peripheral nerve, often the ulnar nerve, and both the number of muscle contractions and the relative magnitude of the fourth twitch compared to the first twitch is assessed. Phase 1 block results in a constant train of 4 ratio, that is the fourth twitch compared to the first twitch, with a uniformly decreased muscle twitch response. Phase 1 block is augmented by cholinesterase inhibitors and depolarizing relaxants, and antagonized by non-depolarizing muscle relaxants. Phase 2 block occurs after prolonged exposure or large doses of Suxamethonium. In this case, the end plate depolarization decreases and the membrane becomes repolarized. Despite being repolarized, the membrane is unable to be depolarized and is now desensitized. The receptors now behave like a non-depolarizing block, resulting in a train of 4 ratio which decreases, known as fade. In this phase, acetylcholinesterase inhibitors and depolarizing relaxants antagonize the blockade, whilst non-depolarizing relaxants cause potentiation of the blockade.
Okay, please classify non-depolarizing muscle relaxants.
Non-depolarizing muscle relaxants can be divided into steroid derivatives and benzoyloquinolinium derivatives. Steroid derivatives include pancuronium, rocuronium, and vecuronium, while benzoyloquinolinium derivatives include atracurium, Sisatracurium, Vs and tuberculin. Non-depolarizing muscle relaxants can also be classified by their duration of action into short, such as Vs, intermediate, such as atracurium, Sisatracurium, Rocuronium, and vecuronium, and long-acting agents, such as pancuronium.
What are the factors that influence the speed of onset of neuromuscular blockade?
The onset of neuromuscular blockade is the time required for 95% depression of first twitch height. This depends on the amount of time needed for the drug to be transferred from the plasma to the neuromuscular junction and for the concentration of the drug at the neuromuscular junction to reach a sufficient level. Factors that influence the speed of onset can be divided into drug factors and patient factors. I'll first start by outlining some drug factors. These include the dose. An increased dose means a faster onset of action due to higher concentration gradient for diffusion. Protein binding. Drugs which have lower protein binding have a faster speed of onset. The drug receptor interaction. Depolarizing drugs have a faster onset of action compared to non-depolarizing agents, as they require 20% receptor occupancy for effect, compared to over 75% receptor occupancy needed for non-depolarizing agents. The potency. There is an inverse relationship between the time of onset of neuromuscular blockade and the potency of the drug. Agents with a decreased potency have a faster onset, as there are more drug molecules available and therefore a higher concentration gradient. And finally, drug interactions. Faster onset occurs with volatile anesthetics, opioids, magnesium, local anesthetics, aminoglycosides, and furosemide. Patient factors also affect the speed of onset of neuromuscular blockade. These can be subdivided into modifiable and non-modifiable factors. Modifiable factors include administration. So there is a faster onset of blockade when the drug is administered into a central vein compared to a peripheral vein due to increased blood flow. Onset of blockade is also faster with intravenous administration when compared with intramuscular. Priming doses are small doses of non-depolarizing muscle relaxants which are not enough to cause neuromuscular blockade. These may decrease the time of onset by occupying a proportion of the receptors, therefore decreasing the time from giving an intubating dose to full neuromuscular blockade. Cardiac output. Increased cardiac output results in an increased speed of onset. And finally, the fluid status. Hypovolemia often results in a faster effect of neuromuscular blockade. Non-modifiable factors include age. Elderly patients generally have a slower onset of action due to decreased cardiac output, whereas neonates usually have an increased proportion of fast twitch muscles and therefore a faster onset of neuromuscular blockade. Pregnancy causes increased cardiac output and increased levels of progesterone, which often results in faster onset of neuromuscular blockade. Muscle type. Muscles with increased blood flow have faster onset, and those with a greater number of fast twitch fibers, such as the eye, have a faster onset of paralysis. And finally, disease states. Myasthenia gravis has a faster speed of onset with neuromuscular blockers that are non-depolarizing, compared with Suxamethonium, where they have a slower speed of onset. Patients with burns and spinal cord injury have changes to their postsynaptic nicotinic receptors, making them more resistant to non-depolarizing neuromuscular blockers and therefore having a slower speed of onset.
Outline the mechanism that potentiate the action of non-depolarizing muscle relaxants and give examples.
So non-depolarizing muscle relaxants function by competitively blocking the acetylcholine receptor. Their action can be potentiated by 5 main mechanisms. Number 1, reducing acetylcholine release presynaptically. Number 2, altering the drug receptor interaction. Number 3, altering the resting membrane potential postsynaptically or by providing membrane stabilizing effects. Number 4, blocking sodium channels postsynaptically, thus preventing depolarization and muscle contraction. And finally, number 5, reducing the metabolism or elimination of the muscle relaxant. We'll just go into these one by one. So firstly, reducing acetylcholine release. Drugs that result in these include aminoglycosides, which compete with calcium at presynaptic terminals, thereby reducing acetylcholine release, and calcium channel blockers, which also block calcium release and result in reduced acetylcholine release. Furosemide is another drug that, interestingly, at low doses can result in decreased acetylcholine release by inhibiting protein kinases, which is required for the release of this neurotransmitter. However, at higher doses, furosemide inhibits phosphodiesterase, which results in increased cyclic AMP and therefore increased acetylcholine release. Therefore, it has dose-dependent effects, with low doses potentiating neuromuscular blockade and high doses antagonizing it. Electrolytes also have an effect on acetylcholine release, with both hypocalcemia and hypermagnesemia resulting in reduced acetylcholine release and thus potentiating neuromuscular blockade. Secondly, altering the drug receptor interaction. An example of this is acidosis, which increases the affinity of non-depolarizing neuromuscular blockers to the receptor and therefore potentiates its effect. The third main category is by altering the resting membrane potential or membrane stabilizing effects. Examples of this include hypokalemia, because in the resting state, the potassium-ion gradient across the end plate is the most important factor which maintains the resting membrane potential. This is maintained at approximately negative 90 millivolts. Hypokalemia causes a decrease in extracellular potassium, which hyperpolarizes the membrane, thus making it more resistant to depolarization. Another example is inhalational anesthetic agents, which stabilize the postjunctional membrane, thus potentiating the effect of neuromuscular blockade. The fourth category is blocking sodium channels. Examples of this are local anesthetics, lithium, phenytoin, which all block sodium channels. Local anesthetics also reduce the neuronal release of acetylcholine and thus also stabilize the postjunctional membrane. Finally, decreased metabolism or elimination of the neuromuscular blocker. Examples of this include renal or hepatic failure. Renal failure can result in increased action of drugs such as pancuronium, which is 80% renally eliminated, whereas hepatic failure can result in increased action of vecuronium and rocuronium, which require hepatic metabolism. Hypothermia and hypovolemia can also cause decreased metabolism and elimination of these drugs.
Okay, let's move on to very commonly used depolarizing muscle relaxant in intensive care, that is Suxamethonium. Can you please outline the pharmacology of Suxamethonium?
So Suxamethonium is a depolarizing neuromuscular blocking agent, which is used to achieve rapid paralysis of skeletal muscles. The pharmacology can be divided into pharmaceutical aspects, pharmacokinetics, and pharmacodynamics. Firstly, thinking about the pharmaceutics. Suxamethonium consists of 2 acetylcholine molecules connected through an acetate methyl group. It comes as a colorless liquid in a 2 ml vial containing 100 milligrams. It is water soluble. The pharmacokinetics can be thought of in terms of the absorption, distribution, metabolism, and elimination. Suxamethonium's absorption, it can be given IV or IM. It has a rapid onset when given IV of 30 to 60 seconds and lasts approximately 10 minutes depending on the dose given. Intramuscular suxamethonium has an onset of action of a bit longer, of about 2 to 3 minutes and can last between 10 minutes to half an hour. In terms of the distribution, Suxamethonium does cross the placenta in small doses. Its metabolism. Suxamethonium is rapidly metabolized by pseudocholinesterase in the plasma, so only about 20% of the initial dose given reaches the neuromuscular junction. The metabolism is prolonged in patients with atypical plasma cholinesterase or reduced activity, such as in pregnancy or liver disease. In terms of its elimination, the majority of Suxamethonium is metabolized by pseudocholinesterase. The remaining amount diffuses away from the neuromuscular junction, and about 10% is excreted unchanged in the urine. Thinking about the pharmacodynamics of Suxamethonium, it binds to the postsynaptic nicotinic acetylcholine receptor, resulting in membrane depolarization. However, unlike acetylcholine, it is not hydrolyzed by acetylcholinesterase, therefore has a longer duration of action and causes persistent depolarization, rendering the sodium channels inactive. This prevents transmission of further action potentials. As a result of its rapid onset, and Suxamethonium is often used for rapid sequence induction at a dose of 1 to 2 milligrams per kilogram intravenously. It is cheap, has a rapid onset, and a short duration of action. However, unfortunately, it also has numerous adverse effects, including bradycardia and arrhythmias, increased intraocular pressure, and can sometimes result in a prolonged neuromuscular block or Sux apnea. It can also cause increased intragastric pressure. Suxamethonium can result in hyperkalemia. A dose of 1 milligram per kilo increases potassium by about 0.5 millimoles per liter in normal patients, but this can be significantly increased in patients with severe trauma, prolonged immobilization, muscular dystrophy, or severe burns. Suxamethonium can also result in anaphylaxis and hypersensitivity reactions, can cause myalgia, malignant hypothermia, and masseter spasm.
Okay, another commonly used agent for rapid sequence induction is Rocuronium. Please describe the pharmacology of Rocuronium and Sugammadex.
So Rocuronium is a steroidal, non-depolarizing muscle relaxant of intermediate duration. It comes as a clear solution containing 10 milligrams a mil and is administered intravenously. It is structurally related to Vecuronium. Rocuronium is 30% protein bound in plasma and is metabolized to some extent by the liver, but mainly excreted unchanged in the bile. Rocuronium is a competitive antagonist of acetylcholine at the pre- and post-junctional nicotinic receptors, thus preventing depolarization. It is given as a dose of 0.6 milligrams a kilogram for intubation, has an onset time of 1 to 2 minutes and a duration of 30 to 50 minutes. Rocuronium has minimal cardiovascular effects, but may occasionally cause tachycardia in high doses. It causes minimum histamine release, but can cause hypersensitivity reactions. Sugammadex is a selective relaxant binding agent used for the reversal of Rocuronium or Vecuronium-induced neuromuscular blockade. It forms a tight, water-soluble complex with these drugs and favors movement of the drug from the neuromuscular junction into the plasma. It comes as a 100 milligram per ml solution and is given intravenously at a dose of 2 to 16 milligrams per kilogram, depending on the depth of neuromuscular blockade. It has a volume of distribution of 11 to 14 liters and is eliminated unchanged by the kidneys. It has a half-life of about 2 hours in patients with normal renal function. Adverse effects include taste disturbance, hypersensitivity reactions, bradycardia, and prolongation of APTT and PT.
So last question, briefly compare and contrast Sisatracurium and Vecuronium.
Both Sisatracurium and Vecuronium are non-depolarizing muscle relaxants, which work by competitive antagonism of nicotinic receptors at the neuromuscular junction. Sisatracurium is a benzylizoquinolinium compound, whilst Vecuronium is an aminosteroid compound. Both drugs are given IV. Vecuronium comes as a 10 mg vial which needs to be reconstituted with sterile water prior to injection, while Sisatracurium comes as a colourless solution with a strength of 2 mg per ml. Both drugs have an intubating dose of 0.1 to 0.2 mg per kilogram and can be given as an infusion to maintain paralysis. Both drugs have an onset time of approximately 3 to 5 minutes and last between 25 to 45 minutes. Sisatracurium metabolism is largely independent of hepatic function as it undergoes Hofmann elimination to form laudanosine and the monoquaternary acrylate metabolite. This then undergoes hydrolysis by plasma esterases, and the laudanosine is further metabolized and excreted in the urine. Vecuronium undergoes some metabolism in the liver to an active metabolite, and 35% is excreted unchanged by the kidneys. Consequently, Vecuronium and its metabolite can accumulate in renal failure, resulting in prolonged duration of blockade. Both agents have minimal cardiovascular effects and do not cause histamine release, but hypersensitivity reactions have been reported.
Okay, so that brings us to the end of the podcast. Do you have any questions?
I have one question for you, as usual.
Okay.
So what happens when acetylcholine falls in love with a receptor?
Muscle contraction?
They have a binding relationship.
Oh. Thanks, Maddi. That was really good. I hope listeners will get out of this podcast. If you have any queries for Maddi or I, please email us to icuprimaryprepcast@gmail.com. Meet you in the next podcast on opioids. Till then, goodbye.
Thanks for listening. See you next time.
See you next time. Bye-bye.